Hi everyone. In the last class, we learned about chronic otitis media, which again is further divided into chronic otitis media mucosal disease or chronic otitis media squamous cell disease. This mucosal disease is the safe CSOM, whereas the squamous cell disease is the unsafe CSOM. Mucosal disease was earlier known as tubertympanic disease, and squamous cell disease was earlier known as aticoandral disease. All these things we have learned, right? How to differentiate between them. That is, mucosal disease will be having a recurrent non-foul smelling mucoid or mucopurulent discharge aggravated by upper respiratory infections or by water entry into the air, whereas squamous cell disease there will be foul smelling scanty purulent discharge which will appear frequently, and there is no relationship with water entry into the air or anything like that. Okay, that means it is a case of chronic squamous cell disease where there is a cholesteatoma causing bone erosion. Okay, all these things we have already learned. Today we will be learning about the complications of otitis media. When will you say that it is a complication of otitis media? What is the definition of otitis media? Whether it is acute or chronic, there should be inflammation in the middle ear, right? It is the inflammation of the mucosal lining of middle ear cleft, that is what is known as the chronic otitis media. Okay, inflammation of mucosal lining of middle ear cleft. Now, if the disease goes beyond the mucosal lining of the middle ear cleft, or if the inflammation is going beyond the mucosal lining of the middle ear cleft, for example, if it is going into the mucoperiosteum, if the by middle ear cleft I mean not just the middle ear, it includes the eustachian tube, middle ear cavity, as well as the mastoid antrum, as well as the mastoid cell system, right? So the mastoid cell system is getting inflamed in an acute otitis media or a chronic otitis media, but it will be confined to the mucosal lining. If it goes beyond the mucosal lining into the mucoperiosteum, it can result in mastoiditis, which is a complication. Okay, so that is why there is a definition for complication. Only if the mucoperiosteum gets involved, it will be considered as a complication. Otherwise, it is the part of the acute otitis media or chronic otitis media. Okay, now the tympanic membrane perforation, which is seen in chronic otitis media mucosal disease as well as squamous cell disease. In mucosal disease, it will be seen in the pars densa, whereas squamous cell disease, it will be seen in the pars flaccida, right? Or it will be a marginal perforation. Okay, now if it is like that, can we call it as a complication? No, it is actually a sequelae of chronic otitis media. To call it a complication, it should be going beyond the mucosal lining of middle ear cleft. Okay, only then you can call it as a complication of otitis media. Now, what are the various complications of the otitis media? It can be divided as intratemporal when it is confined to the temporal bone, or it could be intracranial when it goes into the intracranial cavity. Okay, so this is a broad division of the complications, and I will be going into it soon. Before that, let me ask you, how is this complication spread occurring? Is it confined to chronic otitis media squamous cell disease, the chance of occurring of complications? No, complications can occur in acute otitis media, in tubertympanic disease, squamous cell disease, and even in tuberculous otitis media, which I will be dealing with later on. But for now, just remember that chronic otitis media squamous cell disease has got the highest chance of the complications to occur. Why? The reason is that because when a chronic otitis media squamous cell disease occur, what is happening? There is the squamous cell debris, the keratin debris with desquamated epithelium within the middle ear. The squamous cell type of epithelium should not be present within the middle ear, and the body senses it as a foreign body, and the macrophages and the various inflammatory cells goes on to engulf it, and in the process also engulfs the bony periosteum, and that is what is resulting in granulation formation and the spread of the cholesteatoma. Now, because there is bone erosion, there is high chance of complication in a case of aticoandral disease or squamous cell disease or the unsafe type of CSOM. Okay, that is why the highest prevalence is for the chronic otitis media squamous cell disease. So the first chance how it occurs is by bone erosion. Okay, so bone erosion is the first mechanism by which spread of disease occurs. The second mechanism is by bone erosion occurs in cholesteatoma, right? Cholesteatoma, malignancy, in all these things you can have bone erosion. Now, what is the second mechanism? Second mechanism is through preformed pathways. It could be the natural openings like the oval window, round window, otitis to mastodandrum, okay, or it could be due to a fractural temporal bone, or following stepidotomy, which is iatrogenic spread of infection, right? We are doing something and that is paving way for a pathway for spread of infection. Okay, that is another thing. And what else can lead to a spread of infection apart from the fractural temporal bone, stapedectomy, bone erosion? There could be spread via periarterial spaces of Robin-Virchow. Okay, periarterial spaces of Robin-Virchow. And yes, spread can also occur via thrombophlebitis. Spread can also occur via thrombophlebitis. Okay, so these are the various methods by which spread of cholesteatoma occurs or spread of the inflammation occurs. The first thing, it is via the bone erosion, and that is most commonly seen with cholesteatoma. Okay, cholesteatoma causes bone erosion and that results in the spread of infection. Second thing is via preformed pathways. Now, what are the various preformed pathways that you know? It can be through oval window, round window, or the otitis, or it could be due to some trauma. It could be a fractured temporal bone due to some head injury, and there could be natural dehiscence. Apart from all these, there could be natural dehiscence. Okay, that is facial nerve paralysis can occur in acute otitis media when there is a natural dehiscence in the facial canal. Okay, natural dehiscence in the facial canal. Okay, so that is another pathway of spread of cholesteatoma. Or there could be a natural dehiscence in the area of the tegmen tympani or the sigmoid sinus. Okay, all these can result in spread of cholesteatoma. Okay, and periarterial space of Robin-Virchow and stepidotomy when you are doing a surgery, that can also lead to spread of infection. And the third main mechanism is thrombophlebitis due to the inflammation of the blood vessels. Okay, so this is how the spread is occurring. That is, thrombophlebitis is one mechanism. Another mechanism is through preformed pathway line in tegmen plate. Third mechanism is erosion of bone by the granulation tissue. Okay, so you have to know the three modes of mechanism of spread, and the preformed pathways again further can be divided as through natural openings. Okay, natural openings which include oval window, round window, otitis, or congenital dehiscence. Okay, congenital dehiscence as in facial canal dehiscence. Okay, or what else can cause a preformed pathway? If there is a fractural temporal bone and spread via periarteriolar spaces of Robin-Virchow. Okay, so these are the various mechanisms of spread of infections. Now, among the infections, which is the most common infection to occur, where all the spread can go, this is the otitis, right? Here you have the oval window and here you have the round window. Through the otitis, it can go into the mastodandrum as well as the mastoidae. Now, this is the commonest route of spread of infection, and that can result in the commonest complication of a chronic otitis media or an acute otitis media. And what is that? There is mastoiditis. Okay, mastoiditis. So mastoiditis is the most common complication that can occur. And what is happening in mastoiditis? In acute otitis media or chronic otitis media, the mucosal lining of the midlear cavity along with the mastoidal system is already inflamed. Now, what is happening in mastoiditis? The infection is spreading beyond the mucosal lining. It is going into the mucoperiosteum, and the mucoperiosteum is also getting inflamed. So, how is this happening? We have the midlear cavity here. This is the midlear cavity, and this is the posterior wall of the midlear cavity. This posterior wall of midlear cavity is continuous into the posterior wall of the external auditory canal, and on the posterior wall of the midlear cavity you have the otitis, which forms the opening with the mastoid air cell system. You have the mastoid antrum here, and also you have the multiple mastoid air cells. Okay, these are the multiple mastoid air cells. This mastoid antrum is the largest and the most consistent mastoid air cell. Now, what is happening? Here you have the inflammation of the midlear, right, and for that hyperemia has to occur. So, initially there is hyperemia of the midlear, and this hyperemia is also present in the mastoid antrum as well as the mastoid air cells. Okay, and later on what happens is, because of the hyperemia there will be more and more exudates coming in. Okay, there are exudates coming into the mastoid air cell system, and because of the exudates and the various inflammatory mediators there will be pus formation. Okay, there will be pus formation, and so the mastoid air cell system will be filled with pus. Okay, so the whole of the mastoid air cavity will be filled with pus, and slowly what happens is the intercellular septae will be lost due to the hyperemic decalcification that happens. Okay, hyperemic decalcification later on occurs, and because of that what happens is that the intracellular septae is lost and the whole mastoid cavity will be converted into a single mastoid cavity. Okay, so because of the hyperemic decalcification that occurs, what happens is that this septa will be lost and this whole thing will be converted into a single pus filled mastoid cavity. So that is how the pus formation occurs finally in the mastoid cavity, and that results in the mastoid abscess. Okay, so this is going to be filled with pus like this because it is getting converted into a single cavity because of the hyperemic decalcification. Okay, hyperemic decalcification, and so this is what is known as the mastoid abscess. Now, what happens when there is mastoid abscess here? It is going to spread into the whole of the mastoid air cell system, right? You have mastoid air cell system behind the posterior meatal wall, and because of the abscess, which is initially subperiosteal, it breaks in and then it goes into the posterior meatal wall. This is the posterior meatal wall, right? So the posterior meatal wall sags. Okay, sagging of the posterior meatal wall occurs because of the pus breaking, and that is causing subperiosteal abscess, and because of the subperiosteal abscess you will have the bulge of the posterior meatal wall, and you will be able to appreciate the bulge in the posterior canal wall. Okay, so when there is mastoid abscess, the whole of the mastoid air cell system will be filled with pus. Okay, so this is a typical honeycomb. Okay, now the mastoid air cell system is like this, right? It is having a honeycomb appearance and it is filled with pus now, and that is what is called as mastoid abscess. And on examination you will be able to see that it is an ironed out mastoid that you will be seeing. Okay, the mastoid area will be smooth and congested and red. Okay, smooth, congested and red in appearance, and yes, the pinna will be turned outwards and downwards. Okay, the pinna will go outward, and forward because of the pus formation in the mastoid, and the mastoid will be an ironed out mastoid that you will be seeing. And because there is pus filling the mastoid cavity, and whole of mastoid cell system have undergone hyperemic decalcification, and it is filled with pus, right? So there is a reservoir of pus here, and because of that, whenever you clean the external urinary canal, you can see more and more pus coming out. Okay, even after cleaning, even after suction clearance, there will be more pus coming out, and that is because of the reservoir sign seen in coalescent mastoiditis. Okay, so in coalescent mastoiditis, what is happening? You have hyperemic decalcification taking place, and because of that, there will be sagging of posterior canal wall, and yes, the postauricular groove will get obliterated. Postauricular groove is obliterated, and yes, what else you will be able to see? The pinna will be turned forward and outward, and again you will be able to see the reservoir sign. Okay, so these are the various features of coalescent mastoiditis. When there are no signs of inflammation and still you have mastoiditis, that is what is known as latent mastoiditis. Okay, latent mastoiditis. So when you are having pus within the mastoid, it can spread into various areas. So the abscess, when it is spreading laterally, it is resulting in the pus coming out, right? And that is what is known as the reservoir sign. When it goes posteriorly, it can result in postauricular abscess. Now, what are the various types of postauricular abscess? It is actually having some descriptive names which you have to learn. That is, from the mastoid tip area, when the pus tracks down into the muscles, okay, which are attached to the mastoid tip. What are they? The sternocleidomastoid and the posterior belly of digastric. Okay, when it spreads along the posterior belly of digastric, then that is what is known as the Citley's abscess. Okay, Citley's abscess. If it is going into the sternocleidomastoid, then that is what is known as the Bissol's abscess. Okay, Bissol's abscess. So we have got the Bissol's abscess and the Citley's abscess. These are the two types of abscesses which are seen in relationship to the mastoid tip area, and from the mastoid it can spread superiorly to form zygomatic abscess, and of course you have the sagging of the posterior canal wall that is occurring because of the subperiosteal abscess going into the posterior canal wall, right? And that is what is known as the Lux abscess, which is the meatal abscess. Okay, so Lux abscess is meatal abscess. So these are the various abscesses that you have to learn in relationship to the mastoiditis. Okay, so you have zygomatic abscess, Lux abscess in the posterior meatal wall, and you have the Bissol's abscess and also Citley's abscess. Okay, even parapharyngeal abscess also can occur. Okay, now what else can happen when there is a mastoid cavity infection? The mastoid cavity will be having tenderness, right? When you are having mastoiditis alone, before formation of abscess itself, there will be tenderness, and that is elicited by doing the 3-point tenderness test. Okay, where all will we test for mastoid tenderness? One, in the area of Symbogonga, which directly overlies the mastoid antrum. 2 in the area of mastoid tip, and 3 in the area between them, right? Okay, so these are the 3 areas where you look for mastoid tenderness, and the third area is for looking for the mastoid emissary veins. Okay, and the mastoid tip area is for tip cells. Okay, so this is how you elicit for mastoid tenderness, and that is looked for the signs of mastoiditis. Okay. Now, what are the other complications that can occur when there is a mastoiditis? You can have labyrinthitis, okay, which will be dealt with shortly, and of course facial paralysis also can occur. And this rupture of tympanic membrane, otitis, these are not considered as complications. These are actually the sequelae, okay, sequelae, not complication. Now, this is how an acute coalescent mastoiditis spreading to basal abscess looks like. Now, how will you treat a patient? You can take an X-ray and look for if there is any clouding of mastoid cells. Okay, that can occur when there is a coalescent mastoiditis. Okay, clouding of mastoid cell system can occur, and this is seen in an X-ray. What X-ray will you take? You will take X-ray mastoid lateral oblique view. X-ray mastoid lateral oblique view. Now, what are the various views available? It can be remembered by the code lost MS. Okay, lost MS, because if you don't know this, you are going to lose MS. Okay, so lost MS is for the various views of X-ray mastoid, and what are they? You have the lost view, which is 15-degree lateral oblique view. Then you have the Owen's view, Schuller's view. Schuller's view is 30-degree lateral oblique view. Then you have the Towne's view, the Meyer's view, and Stenberg's view. Stenberg's view. Okay, so among these, the Lowe's view and Schuller's view are the most commonly used view. The Stenberg's view, the modified Stenberg's view, is used for checking if the cochlear implant is in place. Okay, for checking for clouding of mastoid cells, you take an X-ray mastoid lateral oblique view, which is the Lowe's view or Schuller's view. Schuller's is 30-degree, Lowe's view is 15-degree lateral oblique view. Now, what are you going to do when a patient comes to you with mastoiditis? Initially, you can admit the patient and try for intravenous antibiotics. Okay, and if the patient is responding within 24 hours, then in that case you will have to go for surgery. Okay, what surgery will you do? You will do a cortical mastoidectomy. Okay, you will be doing a cortical mastoidectomy, and you can see this is the facial nerve going here. Okay, just posterior to posteromedial ball. So you have to be very careful. Okay, for mastoiditis, you will do a cortical mastoidectomy. Now, if you are having a case of cholesteatoma causing mastoiditis, in that case you will have to go for a canal down procedure or modified radical mastoidectomy. Okay, here when you are drilling, what are the limits of cortical mastoidectomy? What did I tell you? The posteromedial ball anteriorly, inferiorly you have the digastric ridge, posteriorly you have the sigmoid sinus, superiorly you have the tegmen plate. Okay, so these are the limits of the cortical mastoidectomy. Okay, now, so we have learned now the most common complication of otitis media, that is the mastoiditis. And for mastoiditis, you will have to look for mastoid tenderness, sagging of posterior canal wall, then obliteration of the postauricular groove has to be looked for. Okay, then what else will you look for? You will look for the pinna position, whether it is going outward and forward. Okay, all these things we will be checking for in a patient with earache, ear discharge, and most importantly, you will have reservoir sign. What is the sign that you saw in case of acute otitis media? What is that? Yes, lighthouse sign. Lighthouse sign is the pulsatile discharge that comes out, right? This is reservoir sign. Even after you remove the pus, there will be even more pus coming out. That is what is called as reservoir sign. Okay.